So our next talk is by Dr. Elias Traboulsi. He could not be here in person today because of a prior commitment, so he did record his talk earlier. Dr. Traboulsi is the head of pediatric ophthalmology and the director of the Center of Genetic Eye Diseases at Cleveland Clinic. He's also a professor of ophthalmology at the Cleveland Clinic Lerner College of Medicine and director of the ophthalmology residency program at the Cleveland Clinic. His clinical and research interests include the management of genetics of strabismus, congenital cataracts, and the nosology of the ophthalmic and general medical genetic disorders and syndromes, including neurofibromatosis. He has a special interest in ocular developmental biology and ocular malformations, retinal dystrophies, childhood glaucoma, and other common and rare ocular disease of children. And Dr. Traboulsi will talk about the visual obstacles in neurofibromatosis.
Good morning. I'm really sorry not to be able to be with you this day, and I hope you'll forgive me for sharing this virtually with you. I hope it does the job. Today, I've been charged to talk to you about vision challenges in patients with neurofibromatosis. My name is Elias Traboulsi. I'm a pediatric ophthalmologist and a clinical geneticist, and I work at the Cole Eye Institute at the Cleveland Clinic, where I've been for close to 30 years now. I have a major interest in education and expertise in genetic diseases that affect the eye. Let us start by just taking a quick, simplified view of the visual system. We capture images through our eye. The front part comprises the cornea, which is transparent, the lens that focuses the image on the retina and can become opaque, and that's what we would call a cataract. The image is then captured by the retina, which transmits it back via the optic nerve to the brain with a stop in the lateral geniculate body. So we basically see with our visual cortex. And in neurofibromatosis, you can see that a number of things could lead to an interference with this process. What I do not show here is the rest of the brain and where the images coming and captured by the visual cortex are interpreted and put together for us to use for the different tasks and activities and comprehension and actions, etc. So let us start by talking about neurofibromatosis 1 and emphasizing that most patients with NF1 do not have abnormalities that interfere with vision. There may be things we can detect on examination, such as Lish nodules, and these are these brown spots on the surface of the iris, or choroidal hamartomas, and these are also benign tumors of the choroid, which is under the retina, and these are not visible to the regular ophthalmoscopic or looking inside your eye type of examination. We have to take special pictures to reveal them, such as the one I'm showing you here. And these are kind of the lighter colored, brighter spots on the background of this eye, what you see of this retina. And what you see there is the optic nerve, the blood vessels, and parts of the retina. However, NF1 can be associated with vision loss primarily through tumors that directly affect the optic pathways. And we call these optic pathway gliomas. They occur in a minority of patients. I am not absolutely certain about the percentage. I put less than 15%, and it may be 5 or 10%. Maybe some of my neurology colleagues can give us a better estimate of that. However, the tumors that affect the skin can also affect the eyelid and the orbit, and then they can cause a mechanical displacement of the eyelid and interference with its movement and block the line of vision. And certainly, if these fibromas or occur in the orbit, they can also displace the eye. Also, patients with neurofibromatosis 1 can have what we designate as sphenoid wing dysplasia, which is an absence or a distortion of the bone that forms the back of the orbit, and that can also lead to some deformations and effects on vision. What we see here in this image is a glioma of the optic nerve, and it is behind the eye. So when we look inside the eye, we cannot see the glioma. We can see its effect on the optic nerve, and that results in what we designate as optic atrophy. And if you compare on this image what you see to your left to what you see on your right, you notice that the color of the optic nerve is very much different. On your left is a normal color optic nerve. It's kind of pinkish, orangish. On the right, it's more pale and towards white. So that's optic atrophy. And the tumor that is behind the eyeball is compressing the nerve and in a way causing it to lose some of its nerve fiber layers and of its blood vessels, and then the optic nerve color changes and vision is reduced, and parts of your field of vision is lost. We can study the effect of optic nerve pathways of optic gliomas on the optic nerve using a number of things, including photography. You can see there in figure on your left, A on the top, OCT, optical coherence tomography, figure on your left and the bottom, B, and figure on your right, top, A. And these quantitate or give us an estimate of the number of nerve fibers in the optic nerve using a quantitative scale and a color scale. And also on the right and the bottom, you can see a depiction of a field of vision test, which I am sure some of you have taken. Right and left eyes are shown, and this will tell us if the loss of nerve fibers have led to an actual loss of vision in your field of vision. This particular test can be automated, such as this one, and checks the central 24 to 32 degrees of your field, or there are other ways of checking that we do not have time to go into today. So moving to neurofibromatosis 2, here the vision challenges are totally different. The changes involve the lens and the retina. They can involve also the optic nerve, but the ones that are more common and more visible are cataracts, and these are present in 80% or more of patients, and they can be present very early in life or appear a little bit later. They may or may not interfere with vision depending on how dense they are. The other common finding are retinal hamartomas. We spoke about choroidal hamartomas in NF1. These are actually in the retina rather than under the retina. And because they are in the retina, they can distort it, and they can cause a field of vision test and a loss of central vision. On the right, on the top, that whitish line and spot that you see is a hamartoma of the retina. And there is one also in the other eye of that same patient that does not show up very nicely on the image on the top. However, if we did an OCT, and that's the scan you can see in the bottom, you notice that thickening of the grayish part in both eyes, and that is actually the hamartoma that involves the retina. You can think of the OCT as like an MRI of your retina. So it's very sensitive to detect these types of benign tumors. And finally, just like gliomas can affect the optic nerve in NF1, meningiomas can affect the optic nerve in NF2, and they arise rather than from within the optic nerve, they arise from the sheath uh, around the optic nerve. So this is a table that compares the two types of neurofibromatosis and what their eye changes are. Just to recapitulate, with NF1, we have optic pathway gliomas, benign Lish nodules that are very common. The retina is retinal, rarely involved. You can have the plexiform neurofibromas in the eyelids, and the diagnosis in general that is contributed by the ophthalmologist is by skin and iris signs. In NF2, patients can have cataracts. Lish nodules are generally absent. There is the occasional patient with NF2 who may have a Lish nodule. And what is more common are hamartomas and epiretinal membranes, ERM, epiretinal membranes. These are pretty common. The eyelids are rarely involved. And patients, of course, are much more likely to have hearing loss and cataracts. I will end by discussing briefly visual, perceptual, and visual spatial deficits in patients with NF1. I am not an expert in this field, so I will not be able to answer any questions related to these afterwards, but I need to mention them because they are real, and also to remind us all that even if a child has a perfect 20/20 vision, their brain may struggle to process what they see. And children can struggle to understand the spatial relationship between objects, and they have some difficulties with judging line orientation, picking up specific objects from a busy background, etc. Those of you who have children or with NF1 may relate to what I'm talking about. And then there's a visual motor integration. Remember that first slide I showed you with the brain. This doesn't stop with us seeing an object or what's in front of us. We have to also make sense and utilize that information. So this can be problematic in some patients with NF1, certainly not all. And this leads to some reading and literacy challenges that we can call reading disabilities, but they can also be affected by some eye movement disturbances or be labeled as dyslexia, etc. It is also suggested that some children with NF1 would respond better to multisensory reading programs that emphasize touch, movement demands rather than purely relying on visual spatial relation materials. Now, I want to put out that disclaimer again that I am not very familiar with this. I'm mentioning it because I suspect you've all or many of you have experienced that, and maybe you can take it up with others who know much more about this. What we also want to remember is that when there are physical problems with the eye, they create immediate barriers to classroom participation. And in patients with NF1, these are the optic pathway gliomas, amblyopia, or a lazy eye from a drooping of the eyelid and blocking the line of vision, strabismus, ocular misalignment, and we have to remember also that our children with NF1 are the same as the other children. They can develop problems that other children have. They could be nearsighted. They may need glasses. They may develop strabismus. So if you have a disease, doesn't prevent you from getting the problems that a child without the disease would have. And I hope this was informative. I thank you for your attention.